In this presentation, we will discuss the nutrition assessment step of the nutrition care process. The learning objectives are to understand the definition and purpose of nutrition assessment, to understand the components of nutrition assessment, including domains of data and related terms, and to understand how to use information gathered from the nutrition assessment. This section will review the definition and purpose of nutrition assessments, as well as how nutrition assessment data can be gathered. Nutrition assessment is the first step of the nutrition care process, in which pertinent patient data is obtained in a variety of ways. Nutrition assessment is done with every patient encounter. Depending on if it is an initial assessment or a reassessment, the data that is gathered will vary slightly. For example, in an initial assessment, the RD will need to gather more background information about the patient, such as their primary spoken language and their ability to purchase and prepare food for themselves. In a reassessment, since this information will have already been gathered from the patient, the focus will be more on the progress the patient has made since last being seen by the RD. The purpose of nutrition assessment is to obtain, verify, and interpret data that is used to identify nutrition-related problems and their underlying causes, with the use of critical thinking to develop nutrition diagnoses. Without adequate assessment data, the RD is unable to fully understand the status of the patient and what their focus needs to be for their nutrition diagnosis. Nutrition assessment is done by gathering information from a variety of sources, including the patient via patient interviews and physical exams, the patient's medical record, other members of the patient's medical team, and the patient's family members if they are available. By using the different resources available, the RD is able to gather information about their patient, document it properly, and appropriately diagnose and intervene. This next section goes over the different domains that assessment data can be categorized into. There are 5 domains of nutrition assessment data. Each domain is broken down into classes and subclasses with specific terms that have alphanumeric identifiers. Keep in mind that these identifiers do not need to be written out in chart notes, but know that they can be used for data tracking purposes within the electronic medical record. Food and nutrition-related history. This includes food and nutrient intake through diet recalls or food records, food and nutrient administration, or how the patient is receiving their nutrition, whether this is orally or with feeding tubes, for example. Medications that may have nutrient interactions. Complementary or alternative medicines such as herbal supplements. Food-related knowledge, beliefs, or attitudes, including any cultural diet practices. Food and supplies availability, including food insecurity or lack of cooking appliances. Physical activity or function, including normal activity levels or conditions that may affect activities of daily living. And lastly, nutrition quality of life, or how the patient's nutritional status has affected their life on a day-to-day basis. A lot of this information can be gathered through patient interviews and is important to assess. Anthropometric measurements. This includes height, weight, BMI, growth patterns and percentiles for pediatric populations, and weight histories to assess any recent intentional or unintentional weight changes. Much of this information will be included within the medical record when the patient is admitted, but it is important for the RD to confirm these values to ensure their validity. Biochemical data, medical tests, and procedures. This includes laboratory data such as electrolytes, fasting plasma glucose, or hemoglobin A1C, and tests including indirect calorimetry or gastric emptying time. Nutrition-focused physical findings. This data comes primarily from the nutrition-focused physical exam and observations of the patient. It includes physical appearance, muscle wasting, fat wasting, edema, hand grip strength, oral health, such as teeth or dentures present, suck and swallow function, likely coming from the speech-language pathologist evaluations, breathing function, such as if the patient is vented or if they're not, appetite, likely from the patient reports themselves, and affect, or the patient's expressed emotions. Client history. This last domain includes personal history, such as age, gender, and ethnicity, medical, health, or family history, treatments such as chemotherapy for oncology patients, for example, complementary or alternative medicine uses, and social history, including alcohol or tobacco use and the patient's living condition. After assessment data has been collected, the data can be compiled and compared against comparative standards. Using critical thinking to look at the big picture of the patient's condition and nutritional status is important to help identify nutrition diagnoses, as well as identify what nutrition interventions would be appropriate for a particular patient based on the assessment data that was collected. National standards include recommended daily allowances, or RDAs, dietary reference intakes, or DRIs, or the U.S. Dietary Guidelines for Americans, for example. With these national standards, however, it is important to remember that they provide recommendations for an average healthy individual based on their age, so they may not always apply to hospitalized patients. Disease-specific standards are more tailored to fit the needs of patients with specific diseases or conditions. Some examples include ASPEN or ESPEN guidelines for malnutrition, and other guidelines from the National Kidney Foundation, the American Heart Association, and the American Diabetes Association, to name a few. Institution-specific standards are also important to note because different institutions will likely have different guidelines that have been approved for their use. Make sure you know the guidelines of your own facility. In summary, throughout this presentation, we have discussed the different aspects of nutrition assessment. Some key takeaways include that nutrition assessment is the collection and interpretation of data to diagnose nutrition-related problems. There are 5 domains of assessment data. Incorporate use of appropriate comparative standards to help determine nutrition diagnoses for individual patients. In an example, a patient is presented to the ER with shortness of breath. Upon admission, the patient is diagnosed with CHF. In the medical record, the RD identifies assessment data including 56-year-old white male, height 5'9", weight 230 pounds, BMI of 34, classified as obese class 1, no prior medical or family history, tobacco, smokes 1 pack per day, blood pressure at 154/92, triglycerides at 233 milligrams per deciliter, LDL cholesterol at 168 milligrams per deciliter, and HDL cholesterol at 40 milligrams per deciliter. What other assessment data does the RD need to gather? The RD needs more information about typical eating patterns and patient education level. In interviewing the patient, the RD gathers a 24-hour recall. At breakfast, the patient eats 2 muffins with sausage gravy, 2 scrambled eggs, and black coffee. At lunch, he had a chicken salad sandwich made with mayo, celery, and onion on a white hoagie roll with lettuce and tomato, 1 bag of potato chips, 1 small apple, and a 20-ounce bottle of Pepsi. At dinner, the patient had 1 cup of beef stew made with carrots, peas, and potatoes, over 1.5 cups of noodles, 1 slice of buttered bread, and a cup of ice cream. Snacks include 1 bag of microwave popcorn and peanut butter sandwich crackers. The RD also identifies that the patient has limited nutrition knowledge and has never thought about what he ate before. Using this information, the RD is able to properly diagnose the patient and provide education about a heart-healthy diet. The RD will continue to follow and monitor the patient until discharge.